Good afternoon, everybody. It's a wonderful Friday afternoon. It's beautiful and sunny out where I live. I hope it is where you are as well. And it's a little bit after 2 o'clock, so I'm sure at least in British Columbia, we've got a lot of people that are either just starting their shift at work or they're just coming off their shift at work. So I'm not too sure how many people will be tuning in. But I thought it was important to come on and chat about this a little bit today because as we see so often in different Facebook groups, there can be some big discussion and, for lack of a better term, argument that happens around certain things. So I was watching one develop this morning, and I think it may have started last night, where and my buddy Taylor Laviolette was involved in it, and Taylor's a very passionate and much more patient guy than I am, because I tend to not get involved in too many of those discussions, because when you do, you're going to be stuck for the day, going back and having to interact and comment and everything else, and I've just got a lot going on, so I don't have as much time to be able to do that. So I see there's a few people on that are watching right now, so feel free to leave a comment if you like, just to let me know you're there, or just if you agree or disagree with anything that I say as we go. So anyways, this discussion was going on, and it centered around a specific modality. And I don't remember which one it was. I'm not going to call out the modality, but I think what happens is, all too often in our profession, we look at a modality, and some of the argument that was going on around with this was that the science hasn't caught up to the modality yet. This technique is beyond the research. The research hasn't caught up yet. And I hate when I see that, because what that tells me is that if you're treating people and you can't give them at least, it doesn't have to be a 100% accurate description of what you're doing, you should be able to give them at least a simplified explanation of what you're doing. And there's reasons for that, and we'll get into that in a little bit. But whenever we look at a modality, the reality is that every technique that we use works the same. Every single technique works the exact same way. Every time that we put our hands on somebody, it's doing the same thing. So it doesn't matter what acronym it is that your modality does. We're always interacting with the nervous system. So if you've taken a modality course that is telling you that something different than that is going on, then you need to question it. And I think one of the stories that I like to talk about is when I was in college, in, I think it was term 2, we had myofascial release course, and they showed us how to do an occipital hold. And the description was that when you do that occipital hold, you're releasing the fascia around the occiput, and that's relaxing the person, or it's relaxing the tissue, or more specifically in that course, you're releasing the fascia around the occiput. And then in term 7, we took craniosacral therapy. And in that class, they showed us how to do the exact same hold, but then they told us that we were altering the sutures of the cranial bones, and we were altering the rhythm of cerebrospinal fluid. We were doing these different things. So basically, we were taught that you're doing the exact same technique, but there was 2 wildly different descriptions as to what was going on. Whereas in the reality is that it's a highly innervated area that's highly innervated with nerves. And when you do that technique, it feels really good. So fortunately for both classes, the technique itself is phenomenal, and it's a very valuable technique. It's a very effective technique. Patients love it. I have a patient who has asked me to make a mold of my hands so that they can take it home and put it underneath their head because it feels so good, which is great. And that's what we want out of our modalities. But I don't know about you. I know that there's been times in my career where I've gone and taken a new modality and I thought, once I take this modality, I'm going to have so much better outcomes with my patients. This is like the be all end all. And I was willing to invest the money to take level 1, 2, 3, 4. And, the one that I took was an instrument assisted one where I just wanted to use tools on people because I wanted to save my hands. And I thought I was going to make such a difference. Little did I realize that even using a tool, it's the same as putting your hand on someone. It's works the exact same way. So the importance of this is that when we're looking at what continuing education we're going to take, first of all, we need to be able to question the relevance of what we're taking. And then we need to look at what the research says. And I think what's important is that when we look at what the research says, and I've got a note over here on my other screen, when we look at what the research says about musculoskeletal pain and the clinical practice guidelines, and most of the big clinical practice guidelines have been centered around low back pain. But we can apply that, I think, to the rest of the body as well. So when we look at that, there's 3 steps that show us what the best practices are. The first one is reassurance. The second one is education. And the third one is exercise. So I'm going to be talking about exercise. So those are the 3 biggest things that we can do to help our patients. And the fourth one is some manual therapy. So how many of those modality courses have you gone to where those are actually the practice guidelines that they've pointed out and said, this is how you're going to treat the person in front of you? And I'm going to go out on a limb and say that probably not many of them. And yet the research shows us that that is the best approach that we can take. So how are we going to go and provide reassurance to somebody? Especially, I know that we've all probably had the same experiences where you've got somebody who, maybe they've been in a car accident, maybe they've been in a workplace injury or a workplace accident. Maybe it's as simple as they slept on their neck wrong. I know that we've all had that one where it's, I woke up this morning and I have a stiff neck because I slept wrong. I'm not quite sure how you sleep wrong or how you did any damage while you were sleeping, but let's just take that one as an example. How do you provide reassurance to that person who comes in and is having a very painful experience? It's really about understanding what the research tells us and how we can communicate effectively with them. So for a situation like that, I kind of look at the person and say, well, and I remember at a hockey camp a couple of years ago, one of the athletes came in and said, yeah, I slept on my neck wrong. And I said, yeah, number 1 hockey injury out there is sleeping on your neck wrong. And kind of made fun of it a little bit, which maybe wasn't the best approach. But when we look at that, we can reassure them by saying, okay, well, we know that you were sleeping. So the chances that you actually injured your neck or did any tissue damage while you were sleeping is pretty minimal. So that right there takes them from being worried up here down to probably here, because they're still experiencing pain, and we want to validate them in that experience and realize that they are having a painful experience, and we need to recognize that. But showing them that, there's probably no tissue damage that's happened. There's some approaches that we can take that will help you get out of this painful experience that you're in. And show them that they're okay, that there's nothing catastrophically wrong with them. And we're not going to use language that's going to have them catastrophize what's happening, because that's the last thing that we want to do. And then the next thing we're going to do is use a little bit of education. And there's several things that we can do by showing tissue healing timelines, showing them that there's a certain criteria, like ruling out red flags, that shows us you're okay. There's nothing major that's gone on. But then also looking at yellow flags. And yellow flags are things where people are generally concerned that if they move more, they're going to cause damage, or they're worried about moving. So we can have that conversation with them. And it's a really valuable tool that you can use in your practice. And then the third one is exercise. And if you've been following this blog or this page for any length of time, you know how passionate I am about movement and exercise with patients. So how many courses have you gone and take that approach and basically lay everything out for you that says, this is how you approach this patient. These are the things that we're going to rule out. This is how we're going to do this. And now you can provide some manual therapy. Because the reality is, so many of us have taken, I don't know how many manual therapy courses where we're putting our hands on people and we're learning how to touch people. And that's a lot of what we did in massage college, was put your hands on people. This is how you touch them. This is what you do. And the thing is, whatever your favorite technique is that you use, that's the best one to use when it comes to doing manual therapy, because you're confident with it. And when you're able to talk to your patients about it, and they really like that occipital hold or whatever technique it is that you love doing, that's the best one to do. And that's one of the big reasons why your patients come to you. And those are some of the things that we call the contextual factors of treatment, is the fact that they really like what you're doing. You like what you're doing. You're confident with it. You're super confident with putting your hands on people. And that's amazing. But we need to incorporate these other three things into our treatment. And I think all too often, as therapists, we're not doing that. And I could be making a generalized statement. I hope I'm actually making a generalized statement, because I hope there's more people out there that are incorporating that stuff into their practice and into their treatment. But I don't think there's a lot of us that are incorporating movement and exercise into what we're doing. And for those of you who are in a place where they say that exercise isn't part of your scope of practice, then let's just call it movement, because most of that stuff you can just do with people on the table. If you're doing any kind of orthopedic testing before and after your treatment, all that really is active range of motion and passive range of motion. Because we've seen the research that shows us that orthopedic testing has a lot more to do with sensitivity than it does, has more to do with sensitivity than it does specificity. So if you're doing those orthopedic tests, a lot of that is really just a graded exposure to a movement. And yet somebody's telling you that it's not in your scope to do movement. So I struggle with that all the time. And I've had conversations with people about it, but I still struggle with it. So for those of you who are thinking, oh, that's not in my scope, I think it is in your scope. I think it's 100% in your scope. Because as long as you can do active range of motion and passive range of motion, movement or exercise is part of your scope. So I'm sure that you're all understanding why I'm on here doing this. It's to talk about the online course that we've developed, so that you can actually start incorporating these clinical practice guidelines into your treatments. Because we want all of us to be working with the best practices that are available to us, with the best information that's available to us. Because if we're doing that, we're more likely to have better outcomes with our patients. And I think that's what all of us are going for, is not just better outcomes with our patients, but better outcomes in our practice in general. And it's funny, you know, we talk about it and we look at those clinical practice guidelines, and all of us have those patients who come in who just want a really good relaxation massage, and there's absolutely nothing wrong with that. It's where it becomes an issue is when people are depending on you on a regular basis because we aren't following these other things. And that's where we need to make a change. I know in British Columbia here, it's very common because nurses have unlimited benefits and paramedics have unlimited massage benefits, where they can come in almost as much as they want within reason. And not all of them have an injury. They're coming in because they're just sore from work because they've been moving big people around, or they've had something else happen at work where it's not necessarily an injury, but they want to come in and they want to get a little bit of treatment, and a relaxation massage in that case is 100% fine. That's not what we're talking about. But when we look at people who are actually injured and coming in, we want to make sure that we're following those clinical practice guidelines. And that's what I want to help you with. That's what I want to make you confident with. And the perfect thing about it is that you can do it all right in your treatment room. You don't need a bunch of fancy equipment. You don't need a gym, and you don't need all this other stuff. You can do it right in your treatment room. And I 100%, I was going to say fell victim to it, but I think that's the wrong way to put it. But 5 or 6 years ago, I was working at a great clinic, great group of therapists, and decided that I was going to leave and go work at another clinic because that clinic had a gym in it. And I wanted to be able to take people into the gym and do all this great stuff. And then the more experience that I got in it and the more exercise that I did with people, I was like, I don't really need a gym. I can do all of this inside my treatment room. And I want to take all of that and pass it on to you guys and help you guys get confident with that, and realize that it doesn't matter if you have a small little space. It doesn't matter if you don't have a bunch of equipment. You can do whatever you need to do with a little tiny bit of equipment, which is typically some exercise bands. You can do just about everything that you need to do to help people to rehab their injuries and to get out of pain and help them to get to the point that they can self-manage their pain and come to you once in a while when they need it, that they need, a little bit of help getting through that. But I want to help you guys, and I want to help this profession. And I want us all to make sure we're following those clinical practice guidelines for the best outcomes that we can possibly have, so that we can help more people. Because I think all of us got into this profession in order to help people. And the more people we can help, the better. And if we can do it without having to refer out to other practitioners, you can keep people in-house and help them even more, then I think that's going to be a much greater benefit to all of us. So I'm just going to drop a link into the comments, and I'm just working on that now, where you can sign up for the course. And you don't have to take the course by any means. But I want to help as many of you as I can. And I'd love to see you take part in it. And hopefully I'll see you in there. And you're probably going to see a lot of me in the next week, because the registration for the course closes next Thursday night at midnight. And I want to be able to help as many of you as I can. And that was the whole reason that I started this blog, was to help you and help the profession. And hopefully we can all team up and help more people, because that's really what it's all about. Okay, I'll see you guys next time. It's Friday afternoon. Everybody have a great weekend out there. And I'm going to go golfing this afternoon. So get out there and get some sun. And I hope the rest of you are going to go do whatever it is that you love to do this afternoon. All right, we'll catch you next time.